Oh, I don't have my own camera on. Hello, everyone. All of that introduction for nothing. That whole thing for nothing.
It was a nice picture.
It looks better than the real life. So thank you all for coming. Delia, feel free to introduce yourself more than I did.
Great, thank you. Thank you, Aisha. Thank you for the introduction. And I also want to give a bit of a shout out to Ishara. She coordinates these events and secures us. And it's nice that she does that so we can intersect in this way and provide information and hear what your questions are. We always, in addition to providing information, we always learn from our participants as well. I always have a couple questions that baffle me a little bit. And I think, okay, let me look into that and follow up with you. So it definitely improves the presentation for the next time. So as Aisha said, my name is Delia Cortez. I'm a palliative care social worker at Santa Monica, UCLA. So it's the Santa Monica campus. I've been there for a total of 14 years, 4 of which have been in palliative care. Prior to that, I was in the intensive care unit. And I've been in social work and medical social work in one form or another for 20 plus years. So it's been exciting to be a part of this work and to learn from patients and now be able to engage in the community and learn and teach in a different way. So thank you for having me today. Also co-presenting with me will be, go ahead, Brenda Lopez.
Hi, good morning. My name is Brenda Lopez. I recently graduated with my Master's of Social Work from Cal State Northridge. I had the pleasure of interning at UCLA for an entire academic year with Delia and the Palliative Care Consultation Service at the UCLA Santa Monica site. So I really want to give a shout out to Delia for inviting me back to present with her. This is actually my first official presentation where I will be doing a lot of the presentation as well. So I'm really happy for the opportunity to talk to all of you today, and I hope that you find this presentation informative and you walk away with a lot better tools and be able to talk about advanced care planning. So thank you so much.
So we also wanted to touch on a little bit about, I think Aisha, you were talking a little bit about how we're going to use Zoom today. For some of us, including us, it's one of our first presentations that we're doing in this way. So we encourage you to, like Aisha said, you're going to be muted and just hold on to the questions till the end of the presentation. Hopefully a lot of your questions will be addressed as we move through this. You can also use the chat function and we'll be sure to address those. So we're really looking forward to having an exchange with you towards the end of this presentation and ensure that you, like Brenda was saying, walk away with the information that you hope to gather today.
All right, so we're going to get started. So you might have received this form from Ishara. If not, this is what the form looks like. It's called the Go Wish worksheet, and this worksheet is pretty much a list of statements to get you in the frame of mind of thinking of what's important to you. And we will go, along with that throughout the presentation. But what we want you to take away from this is what's important for you now, as well as you move through your life for your future care as well. So at the end of this presentation, our hope is that you will be able to tell people what advanced care planning is. Oftentimes we have seen people ask, what is advanced care planning? They're not really sure what that term is. So our hope is that you will leave with that definition today. Also be able to talk to people about this, so that can include your friends, doctors, nurses, social workers, and be able to initiate those conversations with loved ones as well. And also, the last one, be able to complete an advanced healthcare document, as well as a POLST, which we will also be touching on during this presentation in later slides. So before we dive into advanced care planning, there are a list of common terms that you might come across as you're navigating advanced care planning. For example, the first one is a surrogate decision maker. And what that means is that that's a verbal appointment, and that can happen anywhere and anytime in a clinical setting or a hospital setting. So if for example, if you tell someone like your doctor that, you want this person involved, we will go ahead and document that so then all team members are aware. That also can include family as well as close relatives or friends that you want, that you know well, and they know you well, and they know your instructions well. So then that can inform the plan of care.
If I could just add, we want to make sure that, when we say family, it could mean a lot of different things. It doesn't necessarily need to be someone that is blood related. Family and roles, and they're so dynamic. It could be a really close friend. It could be someone, the bottom line is it's someone that you trust, someone that you can have the discussions that we'll be discussing today. And will follow through, basically be an extension of your voice. So as we move through this presentation, when you hear the term family, please define it as it pertains to you, your life experience, your lifestyle. I just think it's a general term we can use. I just want to make sure that you define it as you prefer.
Thank you.
Should I move on to the next slide now?
Yes, thank you. So what is advanced care planning? And before I give the definition, I do want to say that we are going to be discussing this document, and that document can only be completed when we are as coherent and cognitively intact as we are today. So what that means is that we have full capacity and understanding when completing these documents. If not, there are other things that we will touch on later on as well. So what is advanced care planning? As it states on this slide, it's about learning about the types of decisions that need to be considered, and then considering those decisions ahead of time. So for example, right now that we are able to communicate, that we're able to be in this Zoom session and think about what's important to us, about how we want to be cared for as patients. So ultimately, we have the opportunity to think about these decisions and discuss it with the people that are in our lives, and also letting those people know what those decisions and instructions are. So I think Delia has mentioned this in the past. It's pretty much, this document is like the do's and the don'ts about our healthcare. And we, like Delia said as well, we use this form as an extension of your voice. So we will go through the document and how to complete it in its entirety and how to make it legal in later slides. So I did find a quote that really, speaks to the essence of the purpose of this presentation, which is plan for tomorrow and live for today. So some of the goals of advanced care planning is that, remember, these are ongoing conversations. From experience, and I'm sure that Delia can also add to this, is that it never happens in one sitting. Our goal for you today is not for you to have everything figured out from what advanced care planning is. Just remember that this is the first time maybe some of you are seeing this document or starting to have these conversations with families. So remember that it's going to take a few times for you to, really develop and plan. And most people return with more questions, and we really welcome that because it's really important to plan ahead. So it's important to remember that even when we're completing this document, goals may change, our medical conditions may change, that really could impact our decisions. Our experiences with family members, our relationships with loved ones can change. So all of that stuff needs to be taken into account when completing this document. So as Delia mentioned in the past, we never know when we could be hospitalized, and that can really influence our decisions and how we want to be treated as a patient. So all of these things combined can influence our decision making. So some of the things that can really impact our decisions is conversations around life support, resuscitation, palliative care options, and advanced care decisions. Hopefully right now, I think that we are in a calm and healthier state. We are not in a crisis. We're not in a medical emergency at this moment. This is the best time to really consider completing an advanced care directive. So when it comes to a point where there is a crisis and someone needs to speak on your behalf, they can go ahead and speak for you because those instructions and directions have been already written and documented. So we really truly want your goals, your values, and your beliefs to be reflected on this document. And you can use the Go Wish worksheet to help you, start thinking and reflecting on those things that are what bring you meaning and joy. And I don't know if you wanted to add anything to that, Delia.
No, I think that was great. So now we have some definitions in place. And so why do we talk about this? Why do we provide this education? Why do we think about this? Why do we plan? And some of the reasons are on this slide. When there is a moment of crisis, which Brenda was kind of speaking to, when we go into the emergency room or, there's a fall, something that's unexpected, and we do end up in the hospital, at that time, studies show that about 50% of us will not be able to make medical decisions for ourselves. So for whatever reason, we might be unconscious, we might require, life support, a range of different things could be. So then by default, when someone, needs that level of medical attention, the health system is trained and does rather effectively, will provide interventions to aggressive interventions to intervene and sustain one's life. And that's whether I prefer that or not. So if my healthcare instructions aren't known, this is the system default. All the while, I get this question sometimes in these presentations. Well, if I go to the emergency room, won't they contact my husband, my daughter, my friend? And that's if we can get in touch with that person. Those things are happening in parallel. There's someone like Brenda and I, a social worker, looking for family, looking for a contact. All the while, we do need to take care of this person, this life, while we're trying to find someone and figure out what exactly are the details of his or her health care. And oftentimes it's hard for family members to predict patient or our wishes. I think I know these are very hard discussions to have, and oftentimes we don't engage in them. And so family members, and again, define family as you will. It could be your very close circle of friends. We often don't touch on this. And so when called upon, I've come across quite a few family members say, I'm not sure what my mom would want. I'm not sure what my daughter would want. We never really had those conversations when a crisis hits. And now with, we have a little picture there of COVID, that in itself is a crisis for us. We're all sharing in this experience. We're all impacted in one way or another, or potentially could be impacted. And so that's, I believe, has gotten us into a different frame of mind as well, has shifted things. We're seeing a lot of things on the news, perhaps directly impacted, and it impacts our decision-making, our perspective. Going back to the Go Wish exercise at the beginning of this presentation, I'm curious, I think about if people would have completed that before COVID versus now, kind of sifting through what's important, what defines us, what's important for us to maintain. And I think a pandemic like COVID has kind of really given us a perspective to think about what's important for us, a completely different and unexpected lens. So with that said, if family members are left to say what the plan of care should be, or in other words, what decisions will need to be made, they may be left with some uncertainty and stress if they don't know what the the healthcare instructions are. Maybe some guilt or depression, like, am I making the right choice? Should I do this? Should I do that? And that may linger on. The should-haves, the what-ifs, they linger on, even after the crisis has resolved. And there might be some financial concerns. I get that question a lot in healthcare. What implications do these healthcare decisions have? And that's a very uncomfortable thing for people to ask. They say, I know my sister's in the hospital and she's ill, but I really need to know, if we make this decision, what implication does that have for me? So these are all the sort of discussions that we'll be giving you information on how to hold those discussions. So some of the reasons that we've heard, Brenda and I, that you may have heard, that you may have said yourself on why people don't engage in advanced care planning, or why we don't ourselves engage in advanced healthcare planning, are: I'm healthy. I'm really healthy right now. I'm okay. I can walk my dog. I can go to the market. I'm on maybe a couple medications. I'm pretty good. I don't need to think about that right now. That's for people when they're really sick. My family members and healthcare providers will probably do what I want anyway. Surprisingly, like I said, a lot of these discussions don't happen before the crisis, before the fact. So I could guess what my mom would want based on the person that I know. But if I haven't had a very transparent, clear discussion, I may not know the nuances of her decision making. It really isn't necessary until I am seriously ill. I'll consider it then. But then think about the statistic in the previous slide. About 50% of us in an emergency situation won't be able to make decisions for ourselves. And by default, aggressive measures will be taken. And let me take a step back from that. It's, I say aggressive measures may be taken, and some people would decide to accept those interventions, and that's fine. Nowhere in this presentation are we saying it should be, comfort care or less aggressive measures. The goal here is for your voice to be documented so that who you designate can follow through with your instructions. We want to make sure that you have information on all the options of your care, as well as options on how to document your preferences. I don't have someone to list. I don't have anybody. My family lives really far, or I'm disconnected from them. My children, I'm not so sure, or they live really far. So, but we'll talk about the designation of a healthcare agent if you don't have someone. How do I know what I will want, wish, or instruct? I can't predict, in other words, I can't predict every scenario. How do I know what I'll decide at that moment of crisis? And that's where those reflection exercises really come in handy, come into play. It's really thinking about who you are, what's important to you, and what's important to maintain. I think oftentimes in healthcare, we kind of go in reverse. I hear oftentimes, well, we have this intervention and it could do this for you, but then there's side effects. You might not be able to walk your dog. You might not be able to go to the market. And if those are really important things for me to maintain, is this the appropriate intervention for me? I'll do it later. I don't have time right now. I'll put it on my to-do list. That's got to be one of my favorites. I think it has to involve a lawyer. And I'm not sure if I have time for that, especially in this time of COVID. How do I make a meeting with someone? How do I contact someone that could help me with this? And a lawyer and the paperwork, that's going to cost too much. I'm on a fixed income, or I just don't have a budget for that. And I don't think I can afford that. And honestly, the forms can be overwhelming and intimidating. And so I'm really glad that we're here today to actually give voice to those forms and have an exchange to make them more manageable. And these forms, like Brenda was saying earlier, these forms, the conversations that lead to an advanced healthcare directive or a POLST, it's a series of conversations and reflection. So it does take some time. And I think they're designed in that way so it will be less overwhelming and a bit less intimidating. there are a lot of forms, a lot of advanced healthcare directive forms. If you Google or if you search California advanced healthcare directives, a ton will come up. That in itself is overwhelming. What do you pick? Which one is right for me? And so I always encourage people to look at a couple and see what speaks to them. You'll see here on the slides, and I believe the slides will also be available to you. And if not, we'll make sure they're available. So if you want to refer back to them, you're welcome to do that. A lot of people like the 5 wishes document that you see here, and also prepare for your care. I feel those are very user friendly and walk you through the steps. You know, like if you pick option 1, then go to 2. It guides you nicely. So what the point of this is that there are a lot of forms to choose from. They all have there's no right or wrong choice, as long as it's a California Advanced Healthcare Directive. They all have the same intended purpose. They all may just look a little different or have their sections shuffled a little differently. The layout might be different. I always advise, if you are a person that travels to another state regularly or resides in another state for chunks of time. For example, we have a volunteer that spends 6 months here in California, and then she goes 6 months back east. So I've advised her to have not just a directive here in California, but one in the state that she will be living in for 6 months. And so that's just another layer of letting that healthcare institution or health system that she'll be interacting with know what her instructions are. We've had at UCLA a few patients travel to us for healthcare, and they've been here and they have a directive. I'm thinking of one woman that came from Georgia, and she had it, and we had it scanned in our system, and she did have an emergency moment, and so we had to look at the directive. We did use it as a guide. And we, that was able to tell us who to contact in the event of an emergency. But it's always ideal to have the document completed for the state in which you will be spending the majority of your time in, or you could have dual documents. And for the purpose of today, we'll be utilizing the UCLA Advanced Healthcare Directive. You may have, I believe you all received a link for that, and perhaps the POLST, the Physician's Order for Life-Sustaining Treatment. It's a pink form, or it may be black and white in your link. As Brenda and I were preparing this, we're kind of running on the assumption that maybe you didn't look at the link or you don't have it in front of you. So we'll be moving through it maybe in more detail, just for those people that maybe don't have access to it right now. But again, although we're using the UCLA Healthcare Directive, I would encourage you to also educate yourself on other forms and see what fits for you. So at the beginning of the Advanced Healthcare Directive, it has a nice description, a lot of information that we, and I have the first page on the screen. A lot of what we discussed: introduction to advanced care planning, what it is, the purpose of it, and also what on each page, what you'll see in the Advanced Healthcare Directive. And so this part, as we're reading through it, as we're going through it, it can get a little tough, a little emotional. That's why it's important to again reflect. You'll hear us say that a lot during this presentation. I often advise the people I work with to have a couple of these documents. The first is to use as a worksheet. Write it up, write on it, make your notes. Questions for your doctors, for your nurse practitioners, for your social workers, questions, concerns for your family members, for yourself. I think this document prompts a lot of emotion and a lot of maybe to-dos. And it will help you prioritize the next steps in your care and in your life. So on the following page, oh, I'm sorry, Brenda, that's you.
Okay, you can do it if you want to.
I was on a roll.
You are on a roll right now. Okay, so as Delia was talking about, this is the next 2 to 4 pages. It's really, it's what really speaks to your values and your goals. And like Delia mentioned, we really want you to use this form or whatever form you choose as a guide and a worksheet so you can write on it, make notes, talk to your family. And, you know, like she mentioned, we cannot really stress this enough. These are ongoing conversations and ongoing reflections. So this is where it can get really tough and emotional because it's a heavy topic. You know, you're really talking about really fragile and sensitive things. And it can be uncomfortable for you and the people receiving the information. So the most significant place to start in is reflection with yourself and on your life. So the first statement is a statement of checkoffs for you to consider. And if for any reason, anything that you might want to add is not in those checkbox, if you see that there's a narrative section there, you can go ahead and write anything that you might, you know, didn't find under those checkoffs. And the second question is really talking about life support and what would be acceptable and appropriate for you and decisions for you to make. And again, use this tool and this worksheet as reflection for your healthcare instructions and be able to communicate with your family about those instructions. Let me see, sorry. So
if I could add something you said, Brenda, prompted my thought that these forms are very dynamic and they're, although some of them look very legal and it's a form and some of us stick to filling in the box and the lines, you can definitely add pages to the document. I've seen some very personalized directives that add 2 to 3 pages, and feel free to write in the margins. This should really reflect who you are and what your instructions are. So feel free to add it and edit it as you wish.
thank you. So what are your values and goals, and how do these values and goals influence the plan of care? So Delia and I have gone back and forth and figuring out how to define it. And the best answer that we've came up with is what makes you you, what brings you joy, what's meaningful to you in your life. These are really the things that really inform the medical plan of care. Oftentimes in the healthcare system, we have seen the opposite. We have seen, and I've experienced this too, where there have been times where treatments are offered without knowing if it truly aligns with what the person's values and quality of life are. So for example, if a patient enjoys being active, but interventions may require for a patient to become bedbound, those are all things for you to consider. And remembering that goals are fluid, and it's important to continuously reassess them through reflection and discussions. Do you want to add anything else, Delia, to that? No? So the next page, the next section also continues with your values and goals. And the most important thing for you to take away from this is who you are and how you want to be cared for as a patient as you move through this overwhelming medical setting. So these questions are really just part of the process, but for some patients, these questions may not apply, or they might feel a little overwhelming. So we do want to give you the permission to be able to decide if this is appropriate for you. And if not, you can go ahead and skip some of these questions. It's basically, you can decide what's appropriate for you and what's not.
If I could add, I often get asked the specific directive. The first few pages don't really look like an advanced healthcare directive. I thought it would look a bit more legal. And I would just fill in yes or no or check off certain things. And as you'll see, is if you do some research on directives, advanced healthcare directives, they become more intentional as far as reflecting or giving space for people who are completing it to reflect and document what brings them meaning. Like Brenda was saying, what makes you you? Because that's really important for providers, meaning physicians and other medical professionals, to align the plan of care to who you are. And so this is the start of the document. Although we say use it as a worksheet, it is definitely part of the document. And so if you do complete it and you submit it to your healthcare provider, this should definitely go with it. And so I think that's something that's very unique about this directive, and probably the other one I mentioned, 5 Wishes, where it very much is user-friendly and in kind of narrative in form of writing it up.
So the next page, no, the one before that, Delia, sorry. Thank you. The next page is touching on your beliefs, religious beliefs, and your spirituality. And this is basically for you to write down what you would want your healthcare team to know. You know, what that truly speaks to the essence of who they are and who the patient is. I don't know.
And if some of the sections don't apply, or you're not sure, you can always cross. For those of you that maybe don't have this in front of you, there's, like, for example, a question and then a few lines, like a paragraph to fill in your answers. And so if for some reason it doesn't apply, or you feel I really don't have an answer I want to list for now, you can always cross it out or put not applicable or talk to my healthcare agent, doesn't apply. That's fine. Just because these questions and the space here to complete it is available, you also have the option to skip it if you so choose.
Okay, so choosing a healthcare agent. So I wanted to give the definition and for what is a healthcare agent, and the person that you choose, excuse me, to make medical decisions when you can no longer make those for yourself would be considered your healthcare agent. So this agent, this person, really needs to be aware that he or she has been appointed and designated for this responsibility. So if, you know, this document can be a guide for having those conversations with that person. So let's say, for example, you do not have this document filled out, and if you would like to choose a close friend, for example, to be involved in your care, this person would be, again, considered your surrogate decision maker. This is the verbal appointment that we were talking about. So we would do the same thing. We would, you know, we would tell your doctor, the team, and document it, all that. So then we can, but then again, a surrogate decision maker may have certain limitations and restrictions because there is legal things connected to a healthcare agent. I don't know if you want to add anything to that, Delia?
I do. Something that has come up is, you know, choosing a healthcare agent. In addition to all that Brenda mentioned, sometimes, you know, we often move because of work or different reasons. We move far from our family. I often get asked, well, my daughter lives in England. How is she going to be my healthcare agent? And the distance, the geography really is irrelevant. It's more so that we have a good way to contact that person, a number, an email. I remember once we had a patient come into the ICU and his son was traveling and working in India. That's a huge time difference. And so we had an email. I couldn't get him on his phone number, but I did have an email and said, so we coordinated a time that worked, that miraculously worked for everyone. And we were able to communicate with him, and we set up a time to speak daily at 2 o'clock or whatever it was. And so that worked. So distance, geography, that doesn't matter, as long as, in addition to the criteria that Brenda listed, is that we have a good contact for that person, and that person knows that they're listed as your healthcare agent.
And I also wanted to add, because I think what also intimidates people is that they really truly feel that once they name a healthcare agent, they will no longer be able to be involved in their decisions and in their plan of care. But we want to emphasize that this document only goes into effect when you lack the capacity to make those decisions for yourself. So you are still going to be part of that, part of those decisions, up until you lose capacity to make those decisions for yourself.
And I would add to that, there are some individuals who for a lot of different reasons have capacity and perhaps don't want to be so involved in hearing all the updates, the nuances of their medical condition, and say, you know what, I'd like, for example, my friend Brenda, I want her to start making decisions for me. Go through her. We've talked about it. And that's always, and it's an interesting situation to be in. We definitely verify that with the person that is saying it to make sure there aren't any bias or anything else going on. But if I have the mental capacity to say, I want Brenda to act as my healthcare agent, go through her. That's something that will be followed. So as you see this document, it gives a lot of autonomy and flexibility to again reflect who you are and what your wishes are, and how you want to not just be cared for, but communicated with, and who to involve in that communication.
So how to name your healthcare agent. The criteria for a healthcare agent, it could be anyone that is 18 years or older. And again, someone that you talk to and that you really trust with making these type of decisions for you. From experience of being at the hospital, we had some cases, I think there's one particular situation where I remember where the patient had listed someone as their healthcare agent, and when we tried contacting that person was not aware. That person did not even know that document existed. So you can imagine, the stress that person felt at that moment, having to consider, making decisions for that patient. So remember, it's important to have those ongoing conversations with people that you want to designate. So here you have 2 spaces where you can name people, and the first spot would be considered your primary healthcare agent. If for any reason we aren't able to reach this person, or something has changed, we will go ahead and contact the second person. And I believe Delia mentioned that there's a third option for someone to add a third person as optional. But this is just to pretty much have a backup. I remember I participated with Delia a few months ago in another presentation, and she mentioned that there was a patient who had 4 daughters, and he wanted to give his 4 daughters equal responsibility. He wanted them to be the primary for all decisions. And what Delia explained to this patient is that he really needed to just choose one. And the reason for that was because it's easier for communication between the treating team and the family, and also providing updates. Again, that doesn't mean that they're not going to be involved, like the other sisters were not going to be involved, but this just really allows for more clarity during difficult circumstances and difficult decisions. We've seen it before where, 1 minute family is on the same page, but then an event can happen, or the patient might decline. And then you really do see how the stress levels can go up, emotions can go up, and tension can build. And this really just helps organize everything. And some other responsibilities of a healthcare agent can include, speaking on behalf of the patient when he or she can no longer speak for themselves, being able to choose healthcare providers, also agreeing and providing consent for, certain type of testing, being able to approve or decline medical treatments, being able to donate organs or authorize autopsies, and be able to review medical records. And again, this is in hopes that everything already has been set in place and those conversations have taken place and everything in the document has been documented as such.
Okay, so now we're going to talk a little bit about, there is a page on organ and tissue donation. And so I just want to give you a general overview on what we see and what we know about this to offer you some guidance. And so this is something that can be set up ahead of time, both organ, tissue, and body donation. There are organizations, one of which is listed on this directive. It's the UCLA directive, so it directs you to the UCLA donated body program. There are quite a few other ones in the area, usually medical centers and universities that will have the forms available online for you to complete. And once that's completed, that could be put into your directive and put all together in a packet for when it is needed. For organ donation, if none of this is arranged ahead of time, and let's say you're in the hospital, and usually what happens is your medical team will do a discrete organ and tissue donation screen. It's common protocol for the hospital to screen to see if there are any, for lack of a better word, viable organs or tissue that could be of benefit. And if it's deemed that they are, then you or your family will be involved in discussions. And it's very discreet for specific reasons, such as, it may cause additional distress to talk about this ahead of time. And, if you're in the hospital in that moment of crisis or emergency. And so we want to make sure that there are organs or tissues that can be donated before initiating that discussion. However, if this is important for you, I hear that from quite a few people that they do want to engage in donation, then I would encourage you to look at this page of the document, complete it accordingly, and look at the body donation programs, because this is something that could definitely be arranged ahead of time. And that way, when your family member is approached, would he or she want to donate organs, tissue, or the body? And it's like, I don't know. And there's a lot of mixed feelings about that. I'm not sure. But if you've already set it up, or you've set it up, you've hatched out this page and said, not applicable, I do not want to donate anything, then it's much easier for your healthcare agent to follow through. I think this is a question that family members I see struggle with, because there is uncertainty if it hasn't been talked about. And I have seen that other things have been talked about, a lot of things that we've covered so far, but this is one that oftentimes gets overlooked. And just anecdotally, just my observation is it's something that isn't really considered. And so this document points it out and gives you the opportunity to address it. So now you've completed your Advanced Healthcare Directive. You've taken some of the information that we've given you, you've incorporated it, you've had discussions, you've actually sat down with your healthcare agent and filled in the parts that apply to you. How do you then make it legal? In order for this to be legal, you need to do one of two things. It either needs to be witnessed by two people, and so those two people, they need to be over the age of 18. One of them cannot be a family member. So let's say I'm going to care directive. I could have my sister be one of the witnesses, as long as she's not a healthcare agent as well. And then Brenda could be the other person, since Brenda and I are not related. And also the people that are your witnesses, There's something in the directive that says they can't stand to have any financial gain from your trust, or, they just want to make sure any bias or anything like that is removed from the completion of this document. Or you can have it notarized by a state licensed notary. There are a lot of different, if you have, maybe, I'm not sure if they're still doing it with COVID, but I know AAA has notaries available that will do this. Banks do. There's a lot of traveling notaries. You might know someone that is a friend or family member that can do that for you. So on this same page is where you actually sign, and you need to sign that in the presence of the two witnesses or the notary. Now, I want to emphasize witnesses or notary. I've seen some documents where they've done both just to cover their bases. You don't need to do that. I do advise if there's any complicated family dynamics. I'm pulling on some of my previous experience, what I've learned from patients and families. If, let's say, there are children that don't get along, or there's some inheritance issue. Maybe there's tension between a friend and your cousin. And so those are times where I always advise getting a notary, especially if there might be question later on, the document might be questioned later on in some form, or they might question your capacity. The notary will not review the document and make sure you understand it. Their role is to make sure you know what you're signing, and to make sure that it's you signing the form. But it does make it, in those situations where the dynamics might be a bit more complex, it does hold some weight for it to be notarized, as opposed to having other people, witnesses, signing it, and then that bias might be questioned, or their involvement might be questioned.
If I can add something, Delia?
Mm-hmm, please do.
So right now that we are in this pandemic, I do want to mention that there are a lot of notaries that are still doing, the service, or they are still providing the service. However, you just have to call ahead of time and make an appointment. A lot of them, they are only open certain hours of the day, and some are still providing services mobilely. So it's just a matter of you contacting one near your home, or any services that you might have, and just making that appointment ahead of time. They're not really accepting walk-ins because of COVID.
And so here are the forms for the two witnesses with the same information that we discussed, and also the notary, where the notary seal goes. And it gives you some clear guidelines that we discussed. The witnesses need to be over the age of 18. They must know you and see you sign this form. That's really important. I recently learned, if you do know people that their primary language is not English, so their dominant language is, let's say, Spanish or Russian or Farsi, whatever the case may be, that the notary completing the document needs to speak that language. So they need to be able to communicate with the person, ask them questions. And so can't use an interpreter. The notary has to actually be bilingual and speak that language that is native to the person, or their language of comfort. So I was not aware of that until recently. So I wanted to definitely share that with you all in case you have friends or family members in that situation.
I just wanted to add that we're just at 10:52 and we have a couple questions in the chat. I also wanted to let everyone know that under normal circumstances, Eric Wing in our office is a notary, and he does notary for free for all retirees. But because we're all working remotely, we've been referring people to find a local mobile notary, because we're not doing it on campus, unfortunately.
Great. So we're going till 11, not 11:30.
I think I had 11 on our calendar, okay. But if people can stick around, then let's see.
We should have enough time. We'll go through the next few slides and then get to the questions.
Okay, great. Thank you.
So we also wanted to mention the physician's order for life-sustaining treatment. You should have received a link for this as well. On the screen is a hot pink form. This is a form that is specific to California. This form you cannot Google and find multiple versions. Different states may have different versions, but this is the one that's specific to California. It is basically a physician's order. It must be completed with a physician, nurse practitioner, or your physician's assistant. In a scenario like this, social workers, case managers can, like we're doing, can provide you education over it, can even help fill some of it out, but its completion needs to be with those three providers. And that's intentional so that your physician is sort of forced, your provider is forced to engage you in these discussions about specific preferences that you have for your medical care. Once it's completed, it is legally binding across all healthcare sites in California. And again, it's only valid if it's signed by the provider. So again, physician, nurse practitioner, or physician's assistant, or by you or your healthcare agent, the proxy that you've selected. And so how do you know if you need a POLST? An advanced healthcare directive, anyone over the age of 18 can complete. Anyone. So the POLST was designed for people that are seriously ill, medically frail, and have a chronic progressive condition. One of the guiding questions that we use is, would I be surprised if this person passed away over the next year, sometime during the next year? And if the answer is yes, or if the answer is no, I wouldn't be surprised, then I would want to educate the person on this document and have their physician review it with them. So that's to say, if their life expectancy is within the next year or the next year or less, then this form is something that person should consider. Anything else you want to add, Brenda, to that?
No, that was good.
So here's the next slide. It's basically comparing the advanced healthcare directives and the POLST. We often get questions about, well, if I have one, isn't that enough? Both. Again, we just finished up with the POLSTing. It's for a very specific population, and it's for very specific orders on current care. So it gets much more specific than the advanced healthcare directive. If, let's say, you don't fall under the criteria for POLST, or your physician says, I don't think you need this right now, the POLST, again, as a worksheet, can help you fill out the advanced healthcare directive. If you go through it, some of what you check off, you could include in your directive, or it could be used again as a tool to discuss your instructions with your family.
And I think the biggest takeaway between the two, if you see it highlighted, advanced care directives are for future care and POLST is for current care. So that's one of the biggest differences between the two.
So you've now completed your advanced healthcare directive, maybe even your POLST. It's still an ongoing process. Goals are very fluid. Medical conditions and other life events have an impact on you. So it is important to review and engage in advanced care planning conversations on a regular basis. So here's a list of some situations where if this happens, you may want to revisit. A new medical condition or scheduled surgery is going to happen, or you've been diagnosed with something new. A change in family or healthcare circumstances. You might have listed healthcare agents or people that can no longer provide that support, and you may need to change it. Relocation, you may move to another state and may need to do it, or you may be out of contact with your healthcare agents. You may have new providers, new insurance, new healthcare system. And so this is a time to revisit that and make sure your healthcare team aligns with what your instructions are. And if none of these apply, then you don't need to change anything. You can leave it as such. The documents will live for as long as you need them to. They don't expire unless you change or update the form. You update it. There was a question in the chat from, I think, Gilda, and it ties into this slide. It says, is a handwritten addendum to my official healthcare directive not valid? And in parentheses, you have the equivalent of a holographic will. And the holographic will is basically when you, I believe you don't use a form and you write it all out. You can write it on a sheet of paper and have that notarized or witnessed. And is a California form not acceptable in other states? So the first question I would say, yeah, if you do an addendum, it's not valid. You would need to do a whole new directive. Like I said, you can definitely add sheets to these directives. You can add forms, but it all needs to be all together. It needs to be all together and notarized or witnessed at the same time for it to be all a binding document.
I'm sorry, holographic will, you don't have to notarize and you don't have witnesses, as long as it's in your handwriting. So does that not follow the same, or do holographic wills, have they gone?
You know, when you interface, I mean, we're coming from a medical setting. So when you interface with a medical setting, the common practice is for it to be witnessed or notarized to make sure that, because what the witness and notary are, their function is to verify that it's you completing the document. So let's say you come into the hospital with something written, we would need to verify that you actually wrote those instructions, that you actually are the one providing that information. So there's some wiggle room there for a provider or a family member to say, you know what, I'm not sure if Gilda actually wrote that. You know, so I think having it notarized or witnessed would solidify your document.
I see. So you wouldn't know about wills because you're looking about this healthcare.
Correct.
So that would be for, how about if I have a video of myself, which I would have sent to my kids and say, I'm sending you this holographic will, here it is, and it's your official thing. Would that work?
You know, it's variable. It varies. There's, aside from this, what we're discussing, those alternate forms of documenting your healthcare instructions is very variable on the system itself, as well as for example, their ethics committee. We just had a discussion this morning about a patient who completed an advanced healthcare directive, but didn't have the time, hasn't been able to sign it or notarize it. So is it valid? We know for a fact that he completed it. So it could be used as a guide. We could take it to our ethics committee because we were involved in those discussions. We could say, look, we know that he verbalized this, we documented it, well, that holds some weight. And then they have to weigh in on that. So it is open to some variability and discretion of the system. Now, what you are describing is, you've had some discussion with your children. You've provided them a video.
No,
right? Let's say that was the scenario.
Okay.
And this is important for everyone to know. So you've provided them a video. Perhaps there is where you've stated your instructions and you've talked to them. So there is no healthcare document. We will by default go to your children and say, what do you know about your mom's healthcare instructions? This is a situation we're faced in. What decisions would she make? Now they have a video, they have discussions. You've given them that gift of sharing that piece. So when they relay that to us, that holds a lot of weight, and then we can incorporate that into the plan of care. All of this goes back to communication. We know a lot of also groups and cultures don't subscribe to writing documents down like this. They very much carry the tradition of storytelling and sharing their instructions verbally. So that is very important. That, I think, is the most important step leading to this document. And the second part to your question is a California form not acceptable in other states? Again, it's variable. We see quite a few out of state and they're completed correctly. We take them as valid. Just because it's from a different state, the person still had it notarized or witnessed and signed, and it's thorough, it's a beautiful document. We will accept it, but again, it's variable on the situation and probably the system, the healthcare system that it's in.
We also
Thank
have a
you.
question about someone's
Yes.
advanced care directives being in their, hang on, where'd it go? It's less
It says our
detailed, so
trust
can they
is,
add this one in, like
so
as
it
an
says our
amendment?
trust has a much less detailed set of advanced directives. This is more complete. Can we fill out the UCLA form in addition to the signed information in the trust? Yes, you can. Just make sure it aligns. Yeah, some trusts, some wills are a little vague, and some directives are a bit vague as well. And that's intended, that's on purpose, because you can't predict every medical situation that you'll be in. So you can definitely complete a directive, and I would advise that you compare it to what's in your trust to make sure those two align. And let's see, Maria said that ERRC has a notary on staff.
Yes.
Wang, you went
I
over
think that was the final question. So we normally have the on-staff free notary on campus, but since we're all working remotely, we don't have that benefit anymore. So we have just been telling people to use a mobile notary. Unfortunately, we had to suspend that free service. And I also, before we wrap up, I want to thank Maria for coordinating this with you both as well. So she spearheaded this entire ERRC Cares program, and we are really grateful to have you both here. And Maria did a fantastic job getting this coordinated.
Thank you. I just wanted to, is it okay to go over a couple more slides? I think we have a couple more. We can get those done. Okay, so document distribution. Who should have a copy of an advanced healthcare directive and our POLST, and you might see a list there. It's you, the owner, definitely your healthcare agents, the people you list, any relevant members of the family, again, define family as you will, any agencies that you might be, you frequent. You know, some people go to healthcare, adult healthcare centers, rec centers, and they might have a file for you, so that a place to keep those. Primary and specialist physicians. Of course, if you're in a healthcare system, once it's in the system, it's shared electronically. And someone that will likely visit you in the hospital. Oftentimes, your healthcare agent is out of state. So if you know that friend of mine or my cousin, she's always going to come into the hospital and visit me. That's who you want to have your directive if it's not on file, so they can bring it in for you. Anything you want to add, Brenda, to that one?
No, it's okay.
And then we want to leave you with some statistics to think about. This is one of my favorite slides because it really speaks to the need of advanced healthcare directives and advanced care planning. And it also reflects our hesitancy or maybe reluctance to do so. In California, about 23 of us have written advanced healthcare directives, be it this form or any other form that it takes. However, when we sit down and really think about our wishes, our instructions, how we want to be cared for, how we want our end of life to look like, about 70% of Californians say they would prefer to die at home. And again, home is defined, some people defined in this study, nursing facility, assisted living center, but home as they define it. What doesn't align is that 60% of us currently die in facilities. That doesn't really align with our desires. And so I really want that one of the takeaways I'd like you to leave here with today is really think about these statistics and how you want to be cared for now and in the future, so that who you are is respected in a dignified manner and how you envision it. Thank you for letting us go over a few minutes. As you can tell, we're very passionate about this, and thank you all for your questions and giving us the time to share this with you.
I can't unmute. Oh, there we go. I am unmuted. Thank you so much. Thank you both for joining us this morning. It's a really, really important topic, and we hope everyone has a great takeaway. And if you can send me the slides and you're okay with me sharing them, I will send them to all the participants today. So with that, have a great Monday. Everyone take care, stay healthy, don't touch your face, wash your hands, all those important things. Okay? So thank you, everyone.